Good morning, everybody. Thank you for the privilege of the podium. So, standard disclaimer, I have no disclosures to report. So, in our modern theaters of Iraq and Afghanistan, we've seen a significant change in the pattern of combat injuries. This has been attributed to a drastic increase in highly lethal weapons, namely the improvised explosive device. IEDs are meant to cause massive bodily injury in the form of penetrating shrapnel and blunt injury. To address this, our allied forces have developed and implemented advances in personal protective equipment in the form of helmets, armors, goggles, and then increased safety for our combat vehicles. These advances have resulted in more casualties surviving historically lethal injuries. Although overall mortality has decreased, these casualties suffer significant morbidity in the form of traumatic amputations, traumatic brain injury, and severe abdominal and thoracic trauma. As the confluence of three of the most important systems of the body, the respiratory system, the cardiovascular system, and the airway, thoracic injuries are particularly devastating. Among patients suffering severe trauma, approximately 1/4 of the deaths in the U.S. are attributed to thoracic injury. When evaluating victims of thoracic injury in modern theaters with IEDs and advanced guerrilla warfare, mortality of thoracic injuries in particular has tripled from previous wars. Of those that survive, many develop serious complications, including acute respiratory distress syndrome. Although there are many rescue modalities available stateside for acute respiratory distress syndrome, most are not feasible or available for the soldier treated in theater, leaving few alternatives to care. ARDS is defined as respiratory failure with a decrease in respiratory compliance. It is diagnosed by ventilatory and/or oxygenation deficiencies along with bilateral infiltrates on chest imaging. ARDS is a common cause of morbidity in the critically ill and injured patient, with civilian ICU mortality reaching 26 to 58%. In the combat population, ARDS is also prevalent and was first recognized during World War I. Its close association with combat injury has forced changes in the development, deployment, and application of military medical assets for successful treatment of the wounded soldier. Currently, ARDS affects 26 to 33% of critically injured combatants. It often requires aggressive fluid resuscitation, intensive resources, and expeditious transport to higher echelons of care. Despite early access to care and availability of resources, often the medical needs of the injured soldier far exceeds the capabilities of the combat theater. Therefore, a better understanding of risk factors for the development of ARDS and ARDS mortality will help mitigate the burden of this resource-intense, highly morbid disease process. In hopes of gaining this understanding, our research project objective was to determine the risk factors for mortality in combat wounded patients who developed ARDS on the battlefield. To this end, we designed a retrospective study using the Department of Defense Trauma Registry. We queried this database for traumatically injured patients in the theaters of operation from 2001 to 2015. We then narrowed this set of patients to only include those who were diagnosed with ARDS by ICD-9 code. We assessed these patients by demographics, vital signs, GCS, as well as different laboratory values in the pre-hospital state and upon arrival to the ED. Our outcome was mortality. Using these variables, we did a univariate analysis for mortality with a significance set to p less than 0.05. Using those significant factors, we then did a multivariate logistic regression for mortality. Our results found 182 service members in this registry with a diagnosis of ARDS by ICD-9 code. We had 137 survivors as well as 45 non-survivors for a mortality of 25%. As you can tell from the table, our groups were fairly comparable with the exception of mechanisms of injury showing gunshot wounds, you're more likely to survive, explosions, you're more likely to be a non-survivor, and then injury severity score was higher in our non-survivors. Our higher mortality for ARDS was associated with higher INR, lower platelet count, lower pH, as well as lower base deficit and higher PaCO2. We then included these as well as ISS and mechanism of injury for our multivariate logistic regression. Base deficit, PaCO2, and ISS remain significant with an area under the curve of 0.84. We had quite a few limitations of the study. First and foremost, it was a retrospective analysis with inherent bias. But more importantly, we had sparse data. As we've already mentioned, in-theater documentation is notoriously scarce. Out of almost 100,000 patients in this registry, we only found 182 patients with ARDS by ICD-9 code, which is likely a very a huge underestimate of the actual incidence of this disease process. We also had many variables with minimal data. Most notably, we didn't have any PaO2 data available for this patient subset, so we couldn't do severity data. This prevented us from really comparing our results to other trials that typically stratify mortality based on severity. And then finally, we only include traumatically injured patients, so our results were not generalizable to patients who develop ARDS from a non-traumatic injury. So despite these limitations, our studies show that there are many risk factors associated with ARDS mortality: ISS, INR, PaCO2, pH, and base deficit. Our study's mortality of 25% highlights the need for early intervention for those at risk and the need for innovative strategies for the deployed environment. Future studies, we may look into defining the effect of recent clinical practice guideline changes or deployable rescue strategies like ECMO on the patterns of ARDS mortality. These are my acknowledgements, references, and I'd be happy to take any questions.